So, good evening, ma'am, and good evening, all the participants. I, Shumon, on behalf of Shield Healthcare, welcoming you all in today's webinar. And the topic of the today's webinar is how does embryo quality impact the IVF success? And our guest speaker is Dr. Ratna Chattopadhyay, madam. Before moving into the webinar, let's have a look on our Shield Connect page. This is our Shield Connect page, which is basically a knowledge sharing platform. And here you can find different blogs written by many eminent doctors in many topics. As you can find, there are lots of topics that are available as a blog endorsed by eminent doctors. And these are the past webinars already we have conducted in our platform by many doctors across India. And this is the PCOS awareness blog. Here you can find different blogs related to PCOS in many languages, as well in case of regional languages too. You can see that is Hindi, Kannada, Telugu, Tamil, and many other languages as well. And this is the most important blog in this COVID era time, that is coronavirus awareness blog. Here you can find different coronavirus related blogs in different topics, and already we have conducted various webinars in this coronavirus as well. So you can find these topics here. And the most important thing is our key opinion leaders. Almost 250 to 300 doctors are currently supporting us in this knowledge sharing platform, that is Shield Connect. So I request all the participants, please have a look on this website, as it's a very informative in terms of our subject area. And now it's time to start the webinar. And again, I'm just repeating, the topic of the program is how does embryo quality impact the IVF success? And the speaker of today is Dr. Ratna Chattopadhyay, madam. So it's my pleasure to introduce madam. Madam is the chief embryologist in Institute of Reproductive Medicine in Kolkata. Madam has worked as a research fellow in Cleveland Clinic Foundation, USA. She is the organizing secretary of ISAR 2018 and organizing chairperson of ACE 2020. Madam has many years of teaching experience as well. She teaches FNB students since 2002, working as a faculty in ART training program conducted by IRM since 1990, and also as a faculty in ART training program conducted by IRRH since 2003. Apart from that, madam is the faculty in Department of Physiology of Calcutta University since 2019, and madam has many papers, international papers to her credit, including 25 of international journal papers and 8 book chapters to her credit. And apart from that, madam has a current recent research interest in the idiopathic male infertility and stem cell infusion. So with this short introduction, I request madam to take over the session, and meanwhile I request all the participants for their active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the webinar will be over, we shall have a short discussion on this topic with madam. So thank you very much, madam, for your valuable time, and over to you now.
Thank you, Shuman, for the nice introduction, and good evening to all of you. I am thankful to Shield Healthcare, the organizer, for inviting me to share my knowledge as an embryologist with all of you. My topic of discussion is how does embryo quality impact the IVF, in vitro fertilization success. You know that for in vitro fertilization process, we have to collect both the gametes, the female gametes oocyte and the male gametes spermatozoa outside the body. And then we mix them together in a certain proportion for fertilization in the culture media, which is nothing but physiological salt solution within an equipment known as incubator inside the IVF lab. The fertilized, but this process is known as conventional insemination. But sometimes when there is quantitative and qualitative deficiency in the gametes, mainly the male gametes, we have to inject one alive spermatozoa into the cytoplasm of a mature oocyte, that means Metaphase 2 oocyte, for fertilization. This is called ICSI, intracytoplasmic sperm injection. Then the fertilized oocytes are cultured in culture media to generate the embryos on second, third, or fourth day of the fertilization, or sometimes the blastocyst on 5th day of fertilization. And then the resultant embryo or blastocyst we have to replace or transfer into the mother's womb to achieve conception or pregnancy. This is the whole scenario of the in vitro fertilization procedure. So the first few days of life are nurtured in the IVF lab under the guidance and care of the embryologist. Now, to generate good quality or healthy embryos and to achieve good rate of fertilization, we have to create an atmosphere within the lab which is closely resembled to the mother's womb. For that, the lab is equipped with so many sophisticated instruments. But if there is any error, any deviation in this culture environment, any error in the equipments, any negligence or ignorance of the embryologist, it is difficult to get good quality embryo. So the result following IVF success, IVF cycle will not be up to the mark. We cannot get the success of the following the IVF cycle. So I am going to start today's topic. The success or failure following an IVF cycle depends on three major factors. Number one, embryo quality, which I am going to discuss right now. Number two, endometrial receptivity. Any unreceptive or non-receptive endometrium may cause implantation failure or may reduce the rate of implantation. You know that there are so many factors, molecules, receptor or signaling effect within the endometrium, which are not very clear to us. Endometrium is still the blind box to us. Some of them may be predictive or some of them may be preventive of implantation. Third is the embryo transfer technique, which is the most crucial step in vitro fertilization procedure. Any difficulty during embryo transfer or prolonged embryo transfer technique, again, may cause failure of implantation or may reduce the chances of implantation. Next. Now, good quality embryo does not really mean that they are looking good. Rather, good quality embryos should implant successfully, resulting in higher pregnancy and take-home baby rate. Similarly, next, bad quality embryos are not always bad looking. Bad quality embryos are usually associated with higher rate of aneuploidy, implantation failure, pregnancy loss, and congenital abnormality. Next. Now, the objective of the present study are to define good and bad quality embryos and to correlate embryo quality with the final outcome of IVF cycle. Next. Now, what are the common reasons behind bad quality embryos? Number one, oocyte with inherent defect. You know, embryos are developed or generated from the oocytes. Number two, low Doppler vascularity score of the follicle. Perifollicular vascularity, that is a valuable predictor of oocyte competence. So definitely they predict the quality of the embryos. Then suboptimal culture condition. I discussed that for good embryo formation, good IVF success rate, we need optimum culture environment within the lab. Faults in the ovarian stimulation, though it is the cup of tea for the clinician, but we embryologists should know the idea, because nowadays we are individualization, we do the individualization of the stimulation protocol. We should have some knowledge about the stimulation protocol. Now, improper ovulation trigger or timing of OCR, oocyte retrieval, that also affect oocyte quality, embryo quality, and IVF success rate. The most important factor in IVF success is the advanced maternal age. If it is advanced at maternal age, then there is a decline in the IVF success rate. Then when the oocytes are fertilized by sperm with high DNA abnormality, that cause arrestation of the embryos or blastocyst. Next. Now, upper right picture, the middle oocyte is bigger. It is known as giant oocyte, having double set of chromosome and maybe due to fusion of two eugenia. Chances of fertilization is poor in this particular oocyte. It may develop, or it may be fertilized and develop into a good embryo. You can see the lower left lower picture, there is a good embryo formation from that oocyte, but chances of implantation and continuation of pregnancy is very poor, rather nil. Then upper right, upper right is the oocyte with multiple vacuoles. Again, chances of fertilization and good embryo formation is very low. Lower right oocyte is oocyte with centrally located cytoplasmic granules. Due to it is inherent defect due to cytoskeletal system breakdown. Even after ICSI, intracytoplasmic sperm injection, the fertilization rate is very, very poor. Next. Now, it is low Doppler vascularity score. The perifollicular blood flow is very less. Next. Now, optimum embryo culture condition or optimum culture condition within the lab include temperature at 37 degrees centigrade. Temperature is the most crucial variable in IVF culture system. It has a lot of impact on gamete and embryo function, and mainly it interferes with the stability of the meiotic spindle. Any deviation of temperature may cause disruption of the meiotic spindle. There is aneuploidy, so the success rate is very poor. Now, pH. Actually, no optimum pH has not yet been identified, but there should be a precise control over pH, suppose 7.35 plus minus 0.05. And for that, we need an environment of 5 to 6% CO2 within the incubator. Incubator fire, we do the culture. Incubator is the heart of any IVF laboratory, and IVF laboratory is the heart of any ART clinic. Now, any deviated pH, or if there is any deviation in the pH, it may affect the metabolism, respiration, cell division, cell differentiation, DNA protein synthesis, etc. That may cause altered gene expression and error in imprinting. There may be imprinting disorder. Now, osmolality should be 255 to 298 milliosmol per kg of water. Any change in the osmolality may cause change in the embryo volume, and there may be again altered genetic expression and cytoskeletal damage. Now, the two major factors in the maternal reproductive tract that should be replicated in vitro culture are oxygen tension and VOC, volatile organic compound level. Oxygen tension should be 5 to 7%. Any high oxygen tension may cause oxidative damage of the gametes and the embryos. Now, VOC, these are the derivatives of aldehyde, ketone, and alcohol. In the lab, there may be high VOC level, and these are generated from the embryologist if they use the perfume. That's why we strictly inhibit or prevent to use any perfume, lipstick, nail polish within the lab, or if it is a male embryologist, he should not smoke and enter the lab. At least there should be a gap of 1 hour. Now, moreover, any new equipment that may generate the VOC, and VOC is detrimental for the oocyte and embryo health, and the level should not be more than 5 parts per million. Now, air quality, the air should be clear, dust-free, and air quality in the lab should be class 10,000 clean room. That is globally recommended. That means there should be below 10,000 particle per cubic feet. That create a very clean atmosphere, but for super clean atmosphere, we need class 1000 clean room facility. Yes. When there is any fault in the stimulation protocol, such as too aggressive stimulation protocol, especially in elder age group, just to recruit more follicles. That is not a good idea. There may be lot of abnormal morphology oocyte, what we call dysmorphic oocyte, and there may be high chances of more number of aneuploidy in the oocyte and the embryo. And prolonged stimulation, when higher dose of gonadotropin are used, that may cause zona hardening or thickening. You know, the limiting layer of the oocyte is the zona, and that is a protective coating. But zona thickening may cause entry of the, may prevent entry of the sperm and may interfere hatching process during implantation. So it may cause implantation failure. Next. Now, improper ovulation trigger or timing of oocyte retrieval. You know, the ovulation trigger, timing of ovulation trigger and timing of oocyte retrieval play an important role in IVF success. You know, if there is any disparity or any improper ovulation trigger or timing, the oocyte recovery may be nil, or it may be associated with large number of immature or post-mature oocytes, and that definitely generate bad embryos and the success rate will be decreased. Next. Advanced maternal age, you know that it inversely proportional to the ovarian reserve and oocyte competence. It is associated with chromosomal aneuploidy and decreased mitochondrial activity. So to get good quality oocyte or embryo is difficult, and arrestation of embryo at 4 to 7 cell stage is very common in advanced maternal age group. Next. Now, when the oocyte is fertilized by a sperm having high DNA fragmentation, that negatively correlate with blastulation and pregnancy rate even in good quality oocyte, and high level of DNA fragmentation promote embryo arrest and induce activation of apoptotic pathway. So there may be fertilization, embryo formation, and we can transfer sometimes the blastocyst, but early pregnancy loss is very, very common. Next. Now, criteria of developing good quality embryo. Embryos developing from oocytes originating from follicle with high Doppler vascularity score are associated with higher pregnancy rate compared to those originating from follicle with low Doppler vascularity score. There is a very good paper by the Van Blaerkom. Now, embryos developing from oocytes characterized by well-expanded cumulus, the actually the cell surrounding the oocytes known as cumulus, and sunburst-like corona. It is the immediate cellular layer around the oocyte. It looks like a sun ray, and homologous ooplasm means the cytoplasm within the oocyte that is clear and with fine granules. Round and smooth first polar body. I will show you the picture. If the first polar body is smooth and round, that signifies good quality oocyte. So chances of good embryo formation is there. Thin zona, it should be less than 18, not 20 microns. And birefringent meiotic spindle. You know, meiotic spindle, we cannot visualize by the normal inverted microscope. To visualize meiotic spindle, we need a very sophisticated instrument known as polescope or polarized light microscope. Because of its typical arrangement of the molecules, it has double refractive index. So when polarized light passes through the meiotic spindle, it looks opaque behind a black background. Meiotic spindle is a plate-like structure on which the chromosomal segregation takes place. So birefringent meiotic spindle in oocyte associated with euploid embryo formation. Now, oocytes having this characteristic usually good quality, and good quality oocyte can lead to about 80% Z1 and Z2 zygote, means good quality fertilized oocyte. These are known as zygote. Next. Now here the follicle with high Doppler vascularity score. Next. Now, positive correlation between meiotic spindle retardance, means the brightness of the meiotic spindle, and good embryo formation followed by higher implantation and pregnancy rate was observed. Now, upper right is the metaphase 2 oocyte. Oocyte had the first polar body extruded between 7 to 8 o'clock position. You can see that it is a smooth and round. So it is a very good quality oocyte with clear cytoplasm, thin zona. And when it is observed under the pole scope, you can see the white or opaque structure, that is the meiotic spindle. It is very bright. So oocyte with a birefringent meiotic spindle with high retardance. So it is a good quality oocyte, and it developed into a very good quality embryo, 4-celled embryo on day 2. Next. Now, good quality zygote means fertilized oocyte. Actually, fertilization we can confirm by the presence of 2 pronucleus and 2 polar body within the oocyte. I will show you the picture. And good quality zygote should develop into good quality embryo in optimum culture condition. If the lab quality is good, and if it is under the guidance of a very skilled embryologist, caring embryologist, then definitely it will develop into a good quality embryo. Now, Z1 and Z2 zygote means good quality zygote are characterized by equal number and size of nucleoli in both the pronucleus. So one fertilized oocyte contains 2 pronucleus. That should be at the center of the oocyte. And within the pronucleus, there should be equal number and size of the nucleoli. These are dot-like structure. These are the site of RNA synthesis. And they should be polarized at the PN junction, or they should be equally distributed, scattered in the 2 PN. Now, 2 pronuclei are of equal size and aligned properly. And there should be a clear cytoplasmic halo surrounding the pronucleus. I will show you the picture, then it will be clear. Now, but in time evaluation should be done. We should evaluate the zygote, the embryo, the blastocyst at a proper time. Time of evaluation of PN morphology is 17 plus minus 1 hour post insemination. Actually, the day when we retrieve the oocyte, that is the day 0. And that day, suppose within 4 to 6 hours after, we mix the 2 gametes or inject the male gamete into the female gamete. That is called insemination. And within 17 to 18 hours post insemination, we should confirm whether there is fertilization or not. And fertilization is confirmed by the pronucleus and 2 polar body. Next, you can see the upper pictures contain 3 zygote. The upper left, 2 pronuclei in the middle and 2 polar body. The upper right, there is a clear cytoplasmic halo. The 2 PN, they are aligned with each other, and dot-like structure, these are equally distributed. So these are good quality zygote. They develop into good quality embryos. So we can expect good pregnancy rate from this embryo after transfer of these particular embryos. Next. Now, characteristic of good quality embryo, actually, these are the signs of good embryo formation. Early cleavage is a predictor of good quality embryo. If 26 plus minus 1 hour post ICSI or 28 plus minus 1 hour post insemination, we can see 2-cell stage, it is a good quality embryo. There is high chance of pregnancy. Now, real-time embryo monitoring enable continuous monitoring of the embryos. This is a sophisticated instrument, time-lapse videography, by which we can continuously monitor the embryo along with different timing of different cellular event, by which we can select the good quality embryo. Next. Now, in simple words, the good quality embryos are those with less than 10% fragmentation. Means there is no no speckles of the cytoplasm, or if it is there, it should be 10% of the whole embryo. no multinucleated blastomere. Each cell of the embryo is known as blastomere, and usually one blastomere contains one nucleus. But if multiple nucleus is there, that is not a good sign. There should be stage-specific cell division. On second day of fertilization, there should be 4 cells. On third day of fertilization, 8 cells, like that. And the blastomere should adhere with each other tightly. And blastomere should be of equal size. Uneven blastomere signify bad quality embryo. And large embryo cohort size. That means if all 10 oocytes are fertilized and cleaved, formation of 10 embryo, that is definitely good than if only 3 embryos are formed. Time to evaluate day 2 embryo, that is 44 plus minus 1 hour post insemination. Next. Yeah, look, there are 11 oocytes, all are cleaved. That is large embryo cohort size. So maybe good quality embryos are there. Next. These are day 3 embryo, tightly adhered and no fragmentation, good cell-to-cell contact, and less than 10% fragmentation, blastomere of equal size, no multinucleated blastomere. So these are good quality day 3 embryo, and we can expect implantation from after transferring of these particular embryos. Time of evaluation, 68 plus minus 1 hour post insemination. Next. Now, good quality day 3 embryo in optimum culture condition should grow into a good quality blastocyst. On day 5, we get blastocyst. Blastocysts are developed, and good quality day 3 embryo usually develop into a good quality blastocyst. Now, blastocyst 3AA means the cavity within the blastocyst, which is known as blastocele, filling almost the embryo. There is well-defined compact inner cell mass, more than 60 cells, and a cohesive layer of trophectoderm, and it may result in implantation in more than 70%. Now, time of evaluation, 116 plus minus 2 hours after insemination. Next, you can see it is a good quality, very good quality blastocyst. There is a impact and compact inner cell mass, cohesive layer of trophectoderm, and the cavity inside filling almost the whole embryo. Next. Now, transferring of good morphology euploid blastocyst usually associated with higher implantation and live birth rate. Next. It is a very old embryo scoring system. I am not going into the details. Next. Next. Yes. Now, any deviation from normal may affect IVF success. Too fast or too slow division usually associated with chromosomal abnormality. High degree of fragmentation, more than 25%, may affect implantation potential and is associated with higher percentage of apoptosis and chromosomal abnormality. So we should discard those. Now, embryo with 1 or 2 multinucleated blastomere may develop normally, but embryos with more than 2 multinucleated blastomere indicate chromosomal abnormality. We should discard them. Lack of good cell-to-cell contact in post-thaw embryo, when we are going for the cryopreservation, cryopreserved embryo transfer. If there is lacking in good cell-to-cell contact, it is usually associated with poor implantation. Uneven blastomere are correlated with higher incidence of multinucleation and aneuploidy. And fragmentation more than 25% associated with poor live birth. You know, ploidy means the chromosomal number. If there is any error in the chromosomal number, that is aneuploidy. If there is severe aneuploidy, we should discard that particular embryo or blastocyst. Next. Then, should we transfer poor quality embryos? Yes, when there is no other option. After counseling to the couple, we can transfer, but the chances of live birth rate, chances of implantation and pregnancy rate is very low. But if it implanted, then chances of reaching to the term is almost the same as that of a good quality embryo implantation. Next. It is a Canadian study. Transfer of lower quality embryos based on morphological appearance result in appreciable live birth rate. But the live birth rate is significantly low than that after transferring the good quality embryos. Next. Some undesirable situations we should avoid this, such as clubbing, mixing up good and bad quality embryo during transfer. It is a tendency of the embryologist to transfer good number of embryos, especially in our country, where most of the lab, they are devoid of the genetic analysis, PGD, or just to assess so many sophisticated, it is difficult for them, sophisticated instrument. Mainly we have to depend on the morphology. So as you know that bad looking embryos are not always bad quality embryos. So it is our tendency to mix with good and bad looking embryos together during transfer or during cryopreservation. But it is not a good habit. The bad quality embryo may affect the good quality embryo by generating more reactive oxygen species or other toxic component. Slowly developing embryo should be discouraged for extended embryo culture, as majority of them fail to develop blastocyst and may be associated with chromosomal abnormality. Sperm DNA fragmentation does not impair blastocyst formation. I told you that there may be blastocyst formation, but transfer of this blastocyst may cause early pregnancy loss. Next. So I'm not going into the details of the selection. I told you that most of the embryologists in our country, still they select the embryos on the gross morphology, but morphology alone may not always reveal the truth. I told you that good looking embryos are not always good. So rigorous selection procedure comprising of non-invasive and invasive method has been developed for selection of best embryo, so that the one we choose for transfer is more likely to be viable. Actually, we should discard the non-viable embryos, those embryos which cannot proceed further even after 24 hours of culture. These are non-viable. We can right away discard them. And the embryos which looks very dull, in which all the blastomere are dead, we should discard those particular embryo. But you know, there are some invasive and non-invasive selection procedure. I am not going into the details, but just highlighting those: time-lapse imaging, omics, and other biochemical analysis. These are practicing in some lab as non-invasive method. And invasive method, you know that PGT, pre-implantation genetic testing, which includes PGD, pre-implantation genetic diagnosis, and PGS, pre-implantation genetic screening. But nowadays, they are gradually replaced by the CGH, comparative genomic hybridization. Next. The time-lapse imaging, actually without exposing the embryos outside, without causing too much stress on the embryos, we can get the picture of the embryos. We can know what are the time of different cellular event. And this is the time-lapse imaging system. It is a very sophisticated and expensive instrument, but we can get positive correlation between embryo kinetics and euploidy. This has been reported. Actually, time-lapse is the combination of morphology and the timing of different cellular event. Significant difference in duration of first mitotic phase, first division, has been observed between euploid and aneuploid embryos. So from this imaging system, after just checking the different images, different timing, we can assess which one may be the euploid, which one may be the aneuploid, etc. Next. Omics, you know, the metabolomics means analysis of low molecular weight metabolites, which are secreted or uptaken by the oocyte or the embryos from the surroundings, suppose from the follicular fluid, from the culture media in which they are cultured, such as glucose, glutamate, pyruvate, etc. So by just estimating this, we can assess the idea about the surroundings in which these are the oocyte or the embryos are growing and their health. These are done by the mass spectrometry, ultra performance liquid chromatography. Again, these are very expensive and immediate evaluation is needed, which is not possible for so many ERT center. Next, proteomics, again, study of protein content of the embryo, and amino acid turnover can be evaluated by this metabolic study, but for that we have to sacrifice the embryo. That is not very popular. Secretomics, very popular for non-invasive aneuploidy screening. It is very popular nowadays, just estimation of microRNA or the lipocalin-1 in human spent blastocyst culture media. It can assess the blastocyst aneuploidy. Next. Biochemical analysis, not very popular, but these are used in research purpose. Embryos having early cleavage, increased glucose uptake, and reduced glycolysis are associated with higher pregnancy rate. Increased utilization of amino acid by day 2 embryo, such as leucine, glycine, and asparagine. That's why some component now marketed containing leucine for better quality embryo formation and live birth. Yes, invasive, actually, I told you that PGD and PGS, the two biopsy technique and evaluation technique, the PCR, polymerase chain reaction to diagnose specific genetic mutation. Actually, by PCR and FISH, we can identify which embryo is free from genetic disease or chromosomal abnormality, and accordingly we can transfer that particular embryo in the mother's womb. Now it can be done at different stages: during the fertilized oocyte stage by the polar body biopsy, during cleavage stage by the blastomere biopsy, and during trophectoderm and by trophectoderm biopsy, which is very popular nowadays in case of blastocyst. Next. But the genetic material may not be sufficient for the study, and removal of too many blastomere may reduce the embryo's developmental potential. Moreover, if there is any contamination, that may destroy the whole process, and there may be amplification failure. So nowadays, comparative genomic hybridization or single nucleotide polymorphism gradually replace the PGD as they analyze the whole genomic profile. So these techniques are very common nowadays. You know that our goal nowadays is to identify the developmentally competent embryos so that we can transfer them or we can cryopreserve them for future use. But those which are unfit for reproduction, which are incompetent, we can store them for future research and scientific processes. Next. So take home message I can explain as: poor quality embryos significantly reduces implantation and pregnancy rate, but when there is no other option, we have to transfer those. Number 2, selection of best embryo by suitable method, maybe non-invasive, maybe invasive procedure, and by in-time evolution. You should not miss the time. Then the evolution or analysis may not be proper. And by establishing relationship between oocyte quality, zygote quality, embryo or blastocyst development only improves the success rate and also reduce the multiple gestation rate. If I am confident that this is a best quality embryo or blastocyst, I can transfer a single embryo or blastocyst, and so the multiple gestation rate will be less. And you know, the singleton pregnancy is the ultimate goal of current IVF practice. Thank you. Thank you very much.
Thank you very much, ma'am, for your this informative talk. And if you allow me, then we can take the questions.
Yes, of course. I'll be happy.
Okay, ma'am. So, ma'am, the first question is before intrauterine insemination, what is the relation between the bladder? Should it be empty or should it be filled? So, it's related to the IVF success.
Before, it is same as IUI or embryo transfer procedure. You have to check through the ultrasound whether there is acute retroversion or acute anteversion. If there is acute retroversion, then if bladder is full, then it will help. We always just fill the bladder, ask the patient not to urinate, or we just ask them to drink water before embryo transfer, and it is same as the IUI also.
Okay, ma'am. And my second question is, ma'am, as the DNA fragmentation is an important parameters to assess the success rate. So, is it mandatory to all the patients for the DNA fragmentation test?
No. It is very costly, very expensive. Actually, when there is any doubt, such as after repeated fertilization failure, or there is other abnormality in the male partner, or especially in case of idiopathic male infertility or repeated pregnancy loss, then it is better to investigate the male partner, especially by the DNA fragmentation index.
And ma'am, is there any other specific approach for the poor ovarian reserve patients?
Other specific means we first try with the mild stimulation and just antagonist cycle, but we try to you know that nowadays that these some drugs are there, antioxidant or these testosterone derivatives, and so these can be used for better quality oocyte. But we have seen that if the aged, in case of aged patient, most of the cases there is aneuploidy. You know that after 40 years of age, about 80% of the blastocysts are aneuploid. After near about 43, 44, it may be 95% like that. So it is better try with the mild stimulation or different antioxidant, and it is other such as these drugs are available nowadays. The testosterone derivative, you can try with that, or testosterone patch like that, or you can you can try with the ICSI if the 2 or 3 years, 2 or 3 oocytes are you can retrieve by the IVF procedure, then for better fertilization. But we have seen that there is no added advantage.
And ma'am, one question is from my side specifically, that as you mentioned that the exact atmosphere in the incubator should be maintained to develop a proper embryo. So ma'am, my question is the pH, or whatever you mentioned, it is 7.5, and you are giving the carbon dioxide at
7.35, yes.
Yes, so it is approximately 7 to 7.5, you can say, and there is a 5 to 10% or so carbon dioxide. So ma'am, when the incubator you are opening and closing, so that time some oxygen also can be inserted into the incubator. So the pH may vary, ma'am. So how does it affect to the embryo quality? Does it have any effect?
Definitely. Too much too much opening and closing the
Yes.
door that causes the stress of the embryos. And that's why nowadays this time-lapse videography, when we can continuous culturing system is there. From day 1 to day 5, we cannot open the system. There is one-step media, we are culturing them in one-step media, and on day 5, we are assessing the blastocyst and we are going to transfer them. So when you are opening the door, definitely there is reduction in temperature and the pH. But immediate, the sensor system in such a way that immediate recovery is there, but still some sort of stress always is there over the embryo. But we have to reduce by too many incubators in the lab, especially when the number of cases are more, load is more, or by the time-lapse videography, continuous culture without exposing them outside.
So I could not find, ma'am, any other question. So if you allow me, then we can close today's session.
Okay, thank you.
Thank you very much, ma'am, for your valuable time in our platform. And in future also, I will look forward some valuable session from you.
Okay.
So thank you, ma'am.
Thank you.